My name is Mitchell Burton. I'm currently in my fourth year of studying nuclear medicine at the University of Newcastle. My presentation today is a look at the role of technetium-99m heat damage red blood cell imaging in pancreatic gallium-68 avid lesions. This was a case study which I was involved with at one of my clinical placements last year. It really stood out to me and I thought it was worth sharing. Why? Why is it worth sharing this case study with others? For me, there's three reasons. I think it would be fair to say that nearly everyone in this room has personally or knows of someone who has had an experience with cancer. So, we're all probably mostly aware of the impact on a person's emotional state this diagnosis can have. Currently, it's estimated that 40% of people, so nearly half of us, will develop some form of cancer in our lifetime. 1 in 2 men or 1 in 3 women. I mean, these are just staggering numbers. For me personally, at the start of the year, I had a close family member diagnosed with recurrent malignant melanoma, which had spread beyond the site of occurrence on a PET FDG scan. This was my personal eye-opener to the impact a cancer diagnosis can have on a person. As a developing technologist, I found in the PET department sometimes the speed of the workflow and the concentration required to constantly perform tasks can leave me less empathetic and sympathetic regarding individual patient situations. I would like to think that everyone in the nuclear medicine department is trying their best to have the patient outcome be the best it possibly can be. With these three things in mind in the nuclear medicine world of oncology, I think it's always important to consider the patient's point of view and seek and or at least hope for the best outcome for them. And in the case I will present, it is a perfect example of this. Rather than stating the significance of this for the individual patient, I'll leave the introduction with a question to you. Would you rather have your PET scan be interpreted as what it seems to obviously be and receive the diagnosis of a neuroendocrine tumour, or have the people assessing your scan understand the potentially different reasons for its appearance and ultimately you go home without the diagnosis of a neuroendocrine tumour? Our patient is a 70-year-old male who recently had an incidental finding of a contrast-enhancing lesion on CT. It was non-FDG avid, and it was dotatate avid. He originally presented to the emergency department after the acute onset of umbilical pain, which led to the CT, which incidentally found the lesion. There are a range of other issues present, such as hepatic hemangiomas, arterial enhancing lesions, pontine stroke, biliary calculi, prostatectomy, and appendectomy. He had no recent diagnosis of metastatic disease, no recent abdominal trauma or splenectomy, no contraindications for the labeling or removal of blood were present. December of 2020, 3 scans were performed quite quickly, one after another. The first initial scan was a CT to assess the acute onset of abdominal pain, which incidentally found a lesion in the tail of the pancreas. Further imaging was requested to assess the morphology and physiology of this lesion. Another CT scan was performed, and it was found there was a loss of normal pancreatic lobulation in that lesion. The scan was considered suspicious for a metastatic neuroendocrine tumour. Correlation with its functional status was recommended, so a PET scan using gallium-68 was performed. Intense dotatate accumulation was seen in the region of the pancreatic tail. This further raised suspicion for a neuroendocrine tumour in the pancreatic tail. It was from here that the recommendation to assess whether it was a pancreatic neuroendocrine tumour or an accessory spleen was begun. This is, in my opinion, a very critical point for the patient, as many patients would likely have been diagnosed with a pancreatic neuroendocrine tumour and undergone treatment accordingly. The patient then underwent another CT scan. and the pancreatic tunnel lesion was found stable in size. In the following PET fluorine 18 FDG scan, there was no evidence for a neuroendocrine tumour or any metastatic spread. A subsequent MRI also found the lesion to be stable in size. So to summarise, the patient's position before receiving their heat-damaged red blood cell scan, we have a contrast-enhancing lesion, which is DOTATATE avid, non-FDG avid, and stable in size across anatomical imaging modalities. This leads us to our scan of focus for the case study, a technetium 99M heat-damaged red blood cell scan. The scan was requested to assess whether possible other reasons for the accumulation of DOTATATE were present. In this case, ectopic splenic tissue. There are many names such as accessory spleen, ectopic splenic tissue, splenunculus, or splenunculi for multiple. For the remainder, I'll refer to it as an accessory spleen. So why may an accessory spleen masquerade itself as a neuroendocrine tumour? It all lies in the specific pharmacokinetics of gallium-68 dotatate. As I'm sure most are aware, gallium-68 dotatate is a somatostatin analog, meaning it will bind to somatostatin receptors. These somatostatin receptors are present normally in a range of tissues, but most importantly, in this case, splenic tissue. So obviously, our normal physiological distribution of gallium-68 dotatate will include the spleen. But what if there is a variation in the presentation of our spleen? The crux of it is that a neuroendocrine tumour will accumulate dotatate during PET scanning, and so will an accessory spleen. However, in heat damage red blood cell imaging, a neuroendocrine tumour will not accumulate the damaged red blood cells, and an accessory spleen will. What is an accessory spleen? It has multiple causes. It can be a congenital abnormality, a result of splenic trauma, or a remnant post-splenectomy. Most commonly, they are found in the splenic hilum, with intrapancreatic being second most common. Worldwide, it's estimated 75 million individuals have an accessory spleen within the pancreas. Overall, it's estimated that 400 million people have at least one somewhere. Most commonly, they are found incidentally and are mistaken for pseudopapillary tumours, ductal adenocarcinomas, and hypervascular metastases. Unless an accessory spleen is causing abdominal discomfort, its removal due to an incorrect diagnosis significantly impacts the patient, as they will usually undergo pancreatectomy for subsequent biopsy to reveal it is only splenic tissue. Image the patient. They were collected from the waiting area, ID'd by name, date of birth and address. Their history was collected as previously mentioned, and using a 10ml syringe containing 30 units of heparin and a 19-gauge needle, approximately 2 ml of the patient's blood was withdrawn. The red blood cells were then labelled with technetium 99M, exactly the same as any other red blood cell labelling process using an UltraTag red blood cell labelling kit. Now the critical step is that the technetium 99M labelled red blood cells were placed into a 49.5 degree dry bath for 20 minutes and agitated every 4 minutes. Now, in order to bring the vial back down to an appropriate injection temperature, the vial was placed into an ice bath for 1 minute. Now, 2 minutes after the 1 minute of cooling, 710 megabecquerels of technetium 99M heat-damaged red blood cells were withdrawn from the vial and re-injected into the patient via the left anterior cubital fossa. To understand the pharmacokinetics of the damaged red blood cells, it's important to go back and look at exactly what is happening during the heating and damaging process. When the red blood cells are subject to the 49.5 degree heating, they denature, they fragment, and undergo spherocytosis, meaning they've become spherical rather than their normal biconcave shape. Normal red blood cells can pass readily through splenic tissue. However, after being damaged, their stiffness and rigidity increases and causes splenic sequestration by reticular endothelial cells. This sequestration is what allows imaging specifically of the splenic tissue to occur. The accumulation of the damaged red blood cells into splenic tissue is biphasic until 30 minutes, at which there is then a plateau, and then at 60 minutes post-injection, the optimal target to background ratio is reached for imaging. With our patient, imaging was commenced 58 minutes post-injection. The initial pictures were anterior and posterior simultaneous statics with the suspected area of the accessory spleen placed midfield of view. The patient was positioned supine, arms down, head out. Upon completion of the static images, the patient remained supine and the arms were repositioned above their head. SPECT-CT imaging then commenced of the abdomen. The specific camera parameters are listed in the table, and I'll quickly just run through them. So we had a low energy high res collimator. The imaging went for 1000 K counts, a 256 by 256 matrix, and a 1.31 zoom. Our SPECT was a step and shoot, 30 seconds per view, 32 views for a total of 20 minutes on a matrix of 128 by 128 with a 1 by zoom. Our CT was at a 130 kVp, a 70 MAS, a 2 mm slice thickness and a pitch of 1.5, and our CT recon was on the abdomen window with a B31 kernel and a recon of 2 mm. Looking at our static images here, in the anterior static image, there was physiological tracer accumulation throughout the liver, spleen, kidneys and lungs, with the cardiac pool quite visible. Focal tracer accumulation of a similar intensity to the spleen was seen midfield of view, suggestive of an accessory spleen. Posterior static images show intense physiological tracer accumulation within the spleen and a physiological accumulation within the liver, lungs and cardiac pool. Likely, just due to attenuation, no areas suggestive of an accessory spleen can be seen on the posterior images. Looking now at our SPECT-CT data, I would just like to point out that the images are not of the highest quality, as images were not required for the case study, and what I collected was simply supplemental to the case study text. Looking at our MIP, we can see tracer accumulation consistent with our static images, but the anterior view clearly demonstrates an area of focal damaged red blood cell accumulation. Low-dose CT has the crosshairs centered over the area of interest. However, the poor quality of the CT makes visualization difficult. Our fused SPECT and CT data could do with some intensity modulation to best visualize the lesion. However, an area of focal damaged red blood cells can be appreciated in the area that has the crosshairs. The outcome of this scan was a positive diagnosis for an accessory spleen within the pancreatic tail. Ultimately, this was the deciding factor in whether the patient had a pancreatic neuroendocrine tumor or a common abnormality amongst the population. Had the scan been negative, a diagnosis of a pancreatic neuroendocrine tumor would have been possible, and the most likely outcome would have been a pancreatectomy. Also, had the heat damaged red blood cell scan not been requested, the patient would have likely undergone pancreatectomy to only reveal splenic tissue upon biopsy. Given a true positive result, the patient has just avoided the need to undergo pancreatectomy, which is a significant improvement in the patient's outcome. The impact on the patient's quality of life was also significant by avoiding the personal and familial stress associated with a cancer diagnosis. The nuclear medicine heat damaged red blood cell scan significantly improved the management of this patient.